As Dr. McNeely mentioned, today's talk will be on bone health and prostate cancer, and the subtitle is The Seed, the Soil, and the Farmer's Role. In this metaphor, if hasn't been clear, bone is the fertile soil, while prostate cancer should be really more accurately described as the bad seed. And we as urologists are therefore the farmers, and our role is to protect the integrity of the soil and control the effect of the bad seeds in order to maintain the overall health of the patient. So we'll just start with a quick case here, and we'll just ask one of the R5s, I think Megan is only R5 here, just to give us an opinion of what she would do if this patient came to her clinic. It's Mr. Smith, 64-year-old gentleman with a PSA of 400. You arrange a trust biopsy, which comes back as prostate adenocarcinoma in 10 out of 12 cores with a Gleason score of 4+4. CT scan shows no visceral metastasis and no lymphadenopathy. The nuclear bone scan demonstrated here reveals extensive osseous metastases involving multiple levels in the thoracic spine, lumbar spine, and the sacrum. Megan, what would your thoughts be? Yeah. Bony pain. Yeah. Mm-hmm. That's great. Okay, which brings me then to the to the point. And you can do okay. Yeah. So this case, even though it is quite a severe end of the spectrum of prostate cancer, it really demonstrates the important role that we play in these men's health. The stats here demonstrated from the 2013 Canadian Cancer Society. They're not generally new to us, but I just want to highlight that as we succeed in decreasing the rate of death, we're also faced with more newer challenges. And one of these challenges is managing the effect of prostate cancer on the skeletal system. Patients with breast and prostate cancers, both of which display very high rates of metastases to the bone, are living longer. And because of this, the bulk of the tumor burden may be in bone disease. Therefore, the clinical features associated with cancer-induced bone disease are likely to become more and more prevalent, especially in our patient population. But it's important to also view prostate cancer on the skeletal system as a spectrum. So as demonstrated here in the slide, the skeletal effects can be osteopenia and osteoporosis induced by castration, can be metastases, or can be pathological fractures. I'm not even highlighted here some of the electrolyte abnormalities, such as calcium disturbances. So with that background in mind, we'll just go over the objectives for this talk and then go over how we're going to meet them by giving a quick outline. Our first objective will be to look at the physiological aspects of bone homeostasis and clinical assessment of bone health, and we're going to do this by looking at the role of osteoblasts and osteoclasts. Then we're going to look at bone mineral density and how we're going to measure how this is measured and define osteopenia and osteoporosis. And then we'll look at clinical tools to assess fracture risk stratification. Our second objective will be to discuss the pathophysiology of skeletal metastases in prostate cancer and look at the effect of androgen deprivation therapy, as Megan mentioned. And here we'll look at the seed and soil mechanism and look at the effects of androgen deprivation therapy on the skeletal homeostasis and bone mineral density and the increased rates of fractures. Our third objective will then be to provide an overview of different options for managing skeletal health in patients with prostate cancer. And here we're going to look at the lifestyle modifications and the dietary supplementation. We'll look at the general class of osteoclast targeted therapies, and then we'll look at non-bone targeted therapies effect on the skeletal system, and finally we'll look at the radiopharmaceuticals. So let's start quickly by looking over the normal bone physiology. This is kind of a complicated, detailed slide, but it just highlights that the skeleton is a metabolically active organ that undergoes continuous remodeling. The structural integrity of a healthy bone relies on intricate balance between the bone formation performed by osteoblasts and bone resorption by osteoclasts. So osteoblasts are bone-forming cells, and they form a cell layer over the bone as demonstrated here, on which the matrix is formed and subsequently mineralized to become bone. Osteoblast and bone marrow stromal cells release receptor activator of nuclear factor kappa B ligand. So we'll just call this RANK ligand. As you can see here, that's the green particles. These bind to the RANK receptors on mononuclear progenitor cells, and this process promotes osteoclast differentiation and activation. The pink cells here are the osteoclast, and they are bone-specific macrophages that arise from the monocyte progenitors. And when they get activated, as seen here by binding of the RANK ligand to the RANK receptor, they form a sealed resorption vacuole, as seen here, and then they resorb bone by acidifying this vacuole and secreting lytic enzymes. It's important to emphasize that the RANK ligand and the RANK system is an essential mediator of osteoclast formation, function, and survival. And understanding this will help us understand the function of Denosumab, which is a RANK ligand inhibitor, and bisphosphonates. So how do we clinically assess a patient's bone health? Well, the main way that this is done is through measuring a bone mineral density level, and this is done through a DEXA scan. This is considered the gold standard method of measuring bone mineral density. But bone mineral density is actually a relative term. There's two ways that you can look at it. There's a T-score and a Z-score. The T-score compares the patient's bone mineral density to a young normal adult of the same sex, versus a Z-score, which is compared to age and sex-based reference values. In 1994, the World Health Organization developed diagnostic criteria for assessing a patient's bone health based on the T-scores. So this graph on the right side looks at the T-scores and gives us a reference value. So if anything above 1 standard deviation within that young patient's reference value is considered normal. If the standard deviation of the bone mineral density is between -1 and -2.5, and that's called osteopenia, which is low bone mass, versus less than -2.5 standard deviations away from that reference value, and that's considered osteoporosis. But bone health is more than just an objective measurement. We also have to assess risk factors, and this is mainly considered as age, corticosteroid use history, if the patient has a history of personal fractures or a positive family history of hip fractures. Other comorbidities can also play a key role, such as tobacco use, alcohol use, or any chronic diseases such as diabetes, rheumatoid arthritis, COPD, asthma, or liver disease. And in our patient population, any cancer treatment can also increase the risk of skeletal injury. And this includes chemotherapy and androgen deprivation, which we'll get into more. But when you're communicating with a patient regarding their skeletal health, bone mineral density is a very tough thing sometimes for patients to understand. So an absolute 10-year fracture risk is preferred by physicians to communicate and have a better, meaningful dialogue with the patient about the risks and benefits. In 2005, the Osteoporosis Canada Foundation adopted a 10-year absolute fracture risk system as a preferred method for risk stratification for patients older than 50 years. Since then, there's been several tools to give us an absolute 10-year value of risk, but today we're going to just focus on this one here, as this is the one that's been most validated, which is the World Health Organization model. So as you can see here, this is just a cut and paste from the website, where you can get free calculation tool. You put in the input here for the patient's risk factors and bone mineral density. But it's really important to highlight that these values and these risk stratification are actually country-based, and so the Canadian values are very different from the ones in the US. So it's important to use the Canadian ones. And when you put that in, you get output of a major osteoporotic 10-year risk fracture, and then a hip fracture risk. And why should we really care about bone involvement in prostate cancer? I mean, that's kind of a stupid question, but we really should be caring about it a lot, because the skeleton is the most frequent site of metastasis in advanced prostate cancer. Some estimate involvement between 80 to 90% in men with castrate-resistant prostate cancer. The most common sites of involvement include the vertebral column, the pelvis, the ribs, long bones, and the skull. In addition to subjective bony pain, there's a term called skeletal-related events, SREs. And this is generally considered pathological fractures of any of these bones that we just mentioned, spinal cord compression, need for skeletal radiation, or orthopedic operative intervention. and some people consider hypocalcemia as also in the SREs. And studies have shown that SREs can range between 40 to 50% in patients with metastatic castrate-resistant prostate cancer. With regards to skeletal metastasis, the seed and soil hypothesis provides an excellent theoretical framework for understanding the predilection of prostate cancer cells for bone. This is founded by Dr. Stefan Paget, probably mispronouncing his name, but this was founded in 1889, and this theory describes the skeleton as providing a fertile soil for the germination and growth of cancer seeds. And circulating tumor cells may act as seeds for subsequent recurrences in supportive soil. So these recurrences can occur at either primary tumor sites, known as tumor self-seeding, or they can occur in distant sites, known as bone or example, bone or visceral metastases. It's also becoming evident that the bone microenvironment can harbor circulating tumor cells and provide a secure niche allowing for disseminated tumor cells to survive, and they can evade cytotoxic or pro-apoptotic effects of anti-cancer therapies. So there's several factors that have been shown to contribute to prostate cancer cells going to bone, and it's beyond this talk, but some of the factors include high blood flow to the bone marrow, expression of adhesive molecules on cancer cells that bind them to the bone matrix and stroma, and a rich supply of growth factors to the bone microenvironment. It is a very complex system, and we even have Dr. Gleave and Dr. So and some of the researchers here in the Prostate Center are contributing to understanding the mechanisms further. But I think for the simplicity of this talk, I think we should consider the pathophysiology as a vicious cycle in the bone microenvironment. The cycle involves a bidirectional interaction where the tumor cells produce factors that activate the osteoclasts, and this stimulates them to resorb bone and release bone-derived growth factors. And this in turn influences the aggressive behavior of the tumor cells and causing them to release additional osteoclast activating factors, and the cycle continues on and on. So interruption of the cycle with any drugs that block osteoclast resorption, such as bisphosphonates, will halt the resulting bone loss and also decrease the supply of growth factors to the tumor cells. Now, in addition to bone metastasis, another source of bone pathology in prostate cancer is known as cancer treatment-induced bone loss, or CTIBL. CTIBL is actually a regulatory term approved by the FDA. It helps us appreciate that an otherwise very effective anti-cancer treatment in our patient population, androgen deprivation, can be an important contributor to decreased bone mineral density and increased fracture risk. So we're all aware that patients, that both men and women have bone loss as they age. The figures on the left side here demonstrate naturally occurring bone loss, and you can see that a normal man has 0.5% bone loss every year on average, compared to postmenopausal women. But on the right side, you can see cancer treatment-induced bone loss, and I just want to highlight that the androgen deprivation therapy is actually considerably higher than females with breast cancer who are receiving aromatase inhibitors. So it's actually quite noticeable difference between the two. And how does androgen deprivation therapy affect homeostasis of bone metabolism? This is another diagram that explains the ADT effect on bone metabolism. It's well known that both testosterone and estrogen are essential in regulating bone integrity in men. And you can see here that androgens have a positive effect on bone formation by osteoblast and negative effects on osteoclast. Likewise, estrogens have the same negative effect on osteoclast and indirectly positive effects on osteoblast. So ultimately, both of these function to decrease resorption and maintain bone formation. And given that testosterone undergoes peripheral aromatization to form estradiol, men treated with ADT also have low estrogen states. So low hormonal states are associated with an imbalance between bone resorption and bone formation. And this results in a decreased bone mineral density and increased risk of fractures. And a rapid loss of bone mineral density within the first 12 months of starting ADT has been studied and proven by many researchers. This meta-analysis here looks at different clinical trials and retrospective studies, and it demonstrates that bone loss within 12 months of ADT can range in the lumbar spine from 2% to 8%. And in the femoral neck, it can range from 1.8% to 6.5%. But bone mineral density continues to decline beyond the 12 months of ADT, and this has been proven also by other studies. But even more important is the understanding that bone mineral density is a surrogate marker for fracture risk. So if you decrease bone mineral density, then you increase risk of fractures. So it comes as no surprise then that if you have androgen deprivation therapy, you're going to have increased risk of fragility fractures. And a milestone study published in the New England Journal of Medicine demonstrated this through retrospective analysis of more than 50,000 men. And this is from a Medicare database analysis. Men diagnosed with prostate cancer receiving GnRH agonist, you can see the number of doses. And on the right here, you can look at the rates of fractures, any fracture versus fractures that resulted in hospitalization. And you can see that there's a direct correlation between the number of doses of GnRH agonists and risk of fractures. And the final kind of stepwise understanding is that so ADT causes decreased bone mineral density. Decreased bone mineral density causes increased risk of fractures. And the most important thing now is skeletal fractures have a direct effect on survival. And this has been proven by various studies, not only in prostate cancer patients, but just in general, that in the elderly population, that a fracture can be fatal at times. And this trend also holds true for men with prostate cancer. Based on retrospective data analysis by Ofeline and colleagues, there's evidence to suggest that skeletal fractures is an independent negative predictor of survival in patients with prostate cancer. And this multivariate analysis here on the table demonstrates that this is actually independent from metastatic status. So with that background in mind, the rest of the talk is going to be looking at management options. What can we do to manage these patients who come in with prostate cancer? And what can we do to prevent skeletal complications and to maintain their skeletal integrity? So we're going to go through very quickly options of lifestyle modification and dietary supplementation. We'll focus on osteoclast-targeted therapies, and this includes bisphosphonates and RANKL inhibitors. Then we'll look at the effect of non-bone targeted therapies on the skeletal system, and here we'll just quickly look at abiraterone and enzalutamide. And then we'll quickly also look at radiopharmaceuticals, strontium, samarium, and radium. But instead of presenting it as these management options and data, I thought Dr. So and I were talking, and we thought the best way to present this would be to look at the effects from the perspective of these 5 categories. First, we'll look at patients who are getting androgen deprivation and the treatment-related osteoporosis. What can we do to prevent this or slow it down? And then what about patients who have metastatic prostate cancer that's still sensitive to androgen deprivation? And then we'll compare that to metastatic CRPC patients. And then we'll look at data for prevention of bony mets, and then palliative patients, and what can we offer them for their bony symptoms. So quickly we'll start with the lifestyle modification and supplements. We know that as conservative management in all medicine is probably the first thing that we all should be thinking of, and the main things that we can try to convince our patients is smoking cessation, moderating alcohol and caffeine, performing any type of exercise for skeletal health has been proven, and preventing falls in the elderly. As for dietary supplements, the 2 options that most of us would know would be calcium and vitamin D. Calcium is recommended to be greater than 1,000 milligrams per day for patients greater than 50 years old, and this is recommended by the Canadian Osteoporosis Foundation. And then vitamin D is recommended by the BC Cancer Agency guidelines for patients with prostate cancer to be 800 to 1,000 international units per day. And although this is kind of a baseline place to start, it actually has not been proven to be potent enough. Either of them have not been proven to be potent enough alone for preservation of bone mineral density in patients receiving androgen deprivation. Moving on then, we're going to focus on bisphosphonates and RANK ligands. Bisphosphonates are analogs of naturally occurring inorganic pyrophosphates. They are easily incorporated into bone as their phosphate groups have a high affinity for calcium. Once they get localized to bone, as you can see here in the diagram on the right, They act as inhibitors and even pro-apoptotic to the osteoclasts that encounter and ingest them. But bisphosphonates have a very poor oral bioavailability of approximately 1% absorption from the oral dose. Approximately 50% of the absorbed bisphosphonates rapidly get cleared by the kidneys with a half-life of approximately 1 hour. The remaining 50% get taken up by the bone and may persist there for years. There's various side effects that could occur with bisphosphonates, and these include hypocalcemia, acute phase reaction, renal impairment, and the most severe is osteonecrosis of the jaw. And there's risks. The risks are higher with the stronger potent bisphosphonates and IV regimens. I'm not going to go through all this, of course, but this is just the Canadian bioavailable bisphosphonates. And I just want to highlight one thing, that the oral bisphosphonates are actually quite tedious and require a lot of regimens. So, for example, you have to take it on an empty stomach 30 minutes before the first food or drink in the morning. Some you have to take with a full glass of water, and you can't lie down for 30 minutes after taking it to decrease the risk of esophageal ulceration. So it's not probably the most pleasant medication to take. On the other hand, the other osteoclast-targeted therapy is the RANKL inhibitor, and this is Denosumab. It's a human monoclonal antibody against the RANKL system, and it inhibits the osteoclast formation, function, and survival, as we previously mentioned. This diagram indicates Denosumab as the yellow antibody kind of particles binding to the RANK ligand, the green particles, and ultimately the result is to inhibit the osteoclast function, formation, and survival. Unlike bisphosphonates, this Denosumab does not accumulate in the bone, and it has a longer circulatory half-life of greater than 25 days. Although there is no recommendations for dose adjustments in renal failure, the patients with renal failure are more prone to hypocalcemia, and it's generally not advised for patients with renal impairment just because there's limited studies in this population. So let's talk about some of the evidence here about for osteoclast-targeted therapy for patients receiving androgen deprivation to prevent osteoporosis. So in men with prostate cancer that are still androgen sensitive, there's been multiple studies that showed various bisphosphonates can decrease bone turnover and improve bone mineral density. Probably the most notable of these studies is that published by Smith and colleagues, who performed a 12-month randomized placebo-controlled trial to assess zoledronic acid protection against bone loss in men with non-metastatic prostate cancer receiving androgen deprivation. In this setting, zoledronic acid not only prevented, but it actually improved bone mineral density compared to the baseline baseline values at all skeletal sites. But unfortunately, none of these studies have been proven to improve risk of fractures, but that's, I think, simply just because bone mineral density was used as the endpoint and they were not powered to assess fracture risks. A meta-analysis recently published in 2012 addressed this by looking at 15 articles and looking at patients who are androgen deprivation, who are non-metastatic, and looking at osteoporosis risks for fractures. And they've demonstrated that this is significantly improved by taking various bisphosphonates. Now let's look at the evidence for the RANKL inhibitor and their effect on preventing and decreasing osteoporosis. The strongest evidence for this comes from the HALT 138 study, which is the hormone ablation bone loss trial. This was a multi-center, double-blind, randomized, placebo-controlled trial that enrolled 1,468 men with non-metastatic prostate cancer receiving androgen deprivation. These men were simply at high risk for fractures based on their selection of being older than 7 years old, having low bone mineral density defined as T-score less than -1, or a history of osteoporotic fractures. So quite a high-risk population. And what they did is they took this cohort and they randomly assigned the patients to treatment with Denosumab, 60 milligrams sub-Q every 6 months for 2 years, or they gave them placebo. And the primary endpoint for the study was looking at the % change in bone mineral density at 24 months. Secondary endpoints included incidence of new vertebral fractures. So looking at the results here, these figures represent the mean percentage changes from baseline bone mineral density And this is during just the study period for 24 and then 12 months post-follow-up. And they categorize this according to the skeletal sites and the study group. So if we look here, we can see that Denosumab had significant improvement in all 4 sites, including the lumbar spine, total hip, femoral neck, and distal third of the radius. But more importantly, we can see that patients who received Denosumab, which is described here in the orange or pink, they had a significantly decreased incidence of new vertebral fractures at all 12, 24, and 36 months. And the relative risk for new vertebral fractures with Denosumab is described here, and as you can see, it's improving as you increase Denosumab duration. And adverse events were not significantly different between Denosumab and the placebo group. Moving on to the next group, what about patients who have metastatic disease but are still castration sensitive? The usefulness of osteoclast-targeted therapies in here, unfortunately, is not very well studied. So Denosumab has not been explored as far as we can tell, but bisphosphonates have been assessed, and unfortunately, they have not been shown much benefit. One study here by the Medical Research Council looked at an oral bisphosphonate Clodronate, and to look at the primary endpoint was looking at symptomatic bone progression-free survival or prostate cancer deaths. And what they did here is they looked at initial follow-up at 59 months and then long-term follow-up at 80 years. So the top 2 figures here represent initial results at 59 months. So you can see here on the left that the Clodronate group, which is the dark line here, showed improvement in symptomatic bone progression-free survival. And on the right, it showed that improved overall survival. But unfortunately, when we did the stats, that neither of these were significant statistically. However, in the long-term follow-up at 8 years, there was noted that the Clodronate group had improved overall survival of 22% versus the placebo group, which is 14%. And this was a significant difference. As for Zoledronic acid, for men with metastatic castration-sensitive prostate cancer, this is still under investigation, as displayed here by the clinical trials website. There's one study that took Zoledronic acid and did a randomized double-blind placebo-controlled phase 3 study, and they randomized 680 men with this population that we mentioned to either Zoledronic acid versus placebo. And the primary endpoint was the time to first skeletal-related event or prostate cancer death. The enrollment has been completed, but they are still waiting for the results to be displayed. But I think the key thing that this raises is we must ask ourselves is if patients are getting androgen deprivation and they're responding, is this enough to prevent SREs? And that's something that so far appears that that's the case. What about patients with metastatic castrate-resistant prostate cancer? What can we offer them? From a bisphosphonate perspective, only Zoledronic acid has shown benefit in preventing SREs in this high-risk population. And the main evidence comes from the pivotal Zometa trial led by Dr. Saad from Montreal. And this study randomized 643 men with castrate-resistant prostate cancer and asymptomatic or minimally symptomatic bone metastasis. And they put them to either Zoledronic acid IV every 3 weeks versus placebo. All men in this group continued androgen deprivation, and all received any other therapy at the discretion of the treating physician. They also received vitamin D and calcium. And the primary endpoint here was to assess the portion of men who experienced at least one SRE during the first 15 months of therapy. Looking at the results here, at the 15-month follow-up, you can see that there is an overall improvement in all skeletal-related events of comparison of reduction in 33% versus the placebo group, which had 44%. The left-sided figure here looks at Zoledronic acid median time to develop SRE, and this was significantly longer, of 488 days versus 321 days for the patients treated with Zoledronic acid. Finally, the pain assessment was worse with patients who received placebo, which is the clear bars here, versus those receiving zoledronic acid. And these similar benefits were not displayed here, but these same benefits were demonstrated for at the 24 months long-term follow-up. As for denosumab, in this cohort with metastatic castrate-resistant prostate cancer, this study is the one that really highlights the differences, and it's actually a head-to-head study with denosumab versus zoledronic acid. And this is published 2 years ago in the Lancet. And here, this is a multi-center, double-blind, randomized study where they took this population and randomized them 1,904 men either to zoledronic acid 4 milligrams IV versus placebo. The primary endpoint here was time to first on-study SRE, and this was assessed for non-inferiority, and then the secondary endpoint was assessed for superiority, and to also compare the drug efficacy profile. So at a median duration of approximately 12 months, denosumab significantly prolonged the median time to first on-study SRE by 3.6 months compared to zoledronic acid. So here you can see denosumab is the blue line, and zoledronic acid is the red line, and this was significant improvement in delaying SREs. This was significant both for non-inferiority and for also superiority. Overall survival, which here is displayed on the left, however, was not significantly different between denosumab and zoledronic acid, and time to disease progression was also not different between the two groups. With regards to the adverse effects, there really wasn't too much of a difference other than just noticing hypocalcemia occurred more frequently in the denosumab group. As for prevention of bony mets, now this is also an important topic from the perspective of bisphosphonates, in the sense that none of them have ever demonstrated prevention. The oral clodronate versus zoledronic acid both have not demonstrated prevention of bony mets. But the one to highlight that had somewhat of a promise was the ZEUS trial, which is a European study, and they randomized 1,460 patients, or approximately 1,430 patients, and they randomized it to zoledronic acid 4 milligrams versus placebo, and they wanted to see if that would, in the long term, prevent metastasis. At a median follow-up of 5 years, the rates of development of bony mets were 13.7% in zoledronic acid and 20% in the placebo group. So there's no difference in overall survival, and no difference in bony mets prevention. The only drug that has actually proven to be preventing bony mets is denosumab. And this is based on the 147 trial, which is another randomized controlled trial, which took non-metastatic castrate-resistant prostate cancer patients at high risk of bone metastases, which is defined here as PSA of 8 or greater, or PSA doubling time of 10 months or less. And they randomized this group to either denosumab 120 milligrams sub-Q every 4 weeks versus placebo. And their endpoints were looking at first onset of SREs during the study and death from any cause. The results here are demonstrated. You can see in the left side that bone metastasis-free survival was significantly improved here, and then time to mets was also improved with denosumab versus placebo. However, overall survival here was not different, as there was no difference in time to symptomatic mets. So now we'll just look at non-bone targeted therapies, which include abiraterone and enzalutamide. These agents that are active in controlling the burden of prostate cancer disease improve survival, likely by having a negative effect on bone metastases also. So abiraterone and enzalutamide have recently been shown to improve overall survival and have a beneficial effect on decreasing the rate of SREs in patients with metastatic castrate-resistant prostate cancer. I'm not going to go through the details of the mechanism, but they're just displayed here for us to review. So we'll go over both studies for Abi and for enzalutamide. Abiraterone here in the study is a prospective data analysis where they took nearly 2,000 men with metastatic castration-resistant prostate cancer that have been treated with docetaxel, and they assigned them to either ABI or placebo. After 12 months of follow-up, the ABI significantly improved overall survival, as we know, but also, as you can see here on the left, the ABI group had a delayed time to first SRE, and this significantly decreased skeletal pain compared to placebo, which is shown on the right. As for enzalutamide, there was also another global phase 3 double-blind trial where they took 1,200 men with advanced prostate cancer that have also been treated with docetaxel, and they randomized them in a 2-to-1 fashion for either enzalutamide 2-to-1 ratio versus placebo. The primary endpoint here was overall survival. The study here was stopped after an interim analysis demonstrated improved overall survival benefit. But also, in addition to that, the time to first SRE was significantly longer in the treatment arm compared to placebo. So our last group will be looking at radiopharmaceuticals and their assessment and their use in symptomatic bony mets. So radiopharmaceuticals have become a treatment option for patients with castrate-resistant prostate cancer and symptomatic bony mets. They're systemically administered drugs that localize to the site of bony metastases. And the main thing that we have to consider when we compare them is the type and amount of energy emission that they have, the half-life duration, and the tissue penetrance. This table here summarizes the three radiopharmaceuticals that have been used and shown to be beneficial in prostate cancer patients. This is strontium, samarium, and radium. And the key thing here, just to quickly highlight, is that strontium and samarium are beta emitters versus the new one, radium, which is an alpha emitter. We'll go over the evidence very quickly for each of these radiopharmaceuticals, but just quickly to highlight, strontium and samarium are used for palliative, and then radium is used also for bony mets pain, but it's the only one that's actually been proven to have improved overall survival in this high-risk population. So strontium is the first radiopharmaceutical that was used in 1942. It's a calcium analog with a long half-life of greater than 50 days, and it has a high energy average beta emission compared to the others. The average soft tissue range of this agent is 2.4 millimeters, and has been used since the 1990s for palliation of bony pain. This landmark study is the one that kind of initiated this, and they pretty much looked at strontium adjuvant use treatment for in addition to local external beam radiation. And although it showed no difference in overall survival and decreased analgesic use and increased time to further radiation, it did not decrease number of new painful mets. In comparison to strontium, samarium-153 binds to hydroxyapatite crystals in the areas of high bone turnover. It has a short half-life of 1.9 days and a low energy emission of also beta rays. It has an average soft tissue range penetrance of 0.6 millimeters. The benefit for samarium is also very similar to strontium in the sense that it's also known to benefit patients with painful bony mets and castrate-resistant prostate cancer. It also did not show any difference in overall survival, but it did show improved pain scores, decreased analgesic use as demonstrated here by the squared line, and transient myelosuppression was the only side effect for it. Our last one that we're going to look at is radium-223, and this is the newest one that's out there. It's a calcium analog, and it has high energy alpha emission. And what it does is that it induces DNA double strands and causes apoptosis at all cell cycle stages. A really unique feature of this drug is that it has a 0.1 millimeter soft tissue penetrance, which is an average of 2 to 10 cells diameters. So this minimizes myelotoxicity significantly. And 6 months ago, the results for the pivotal study of alpha-radin in symptomatic prostate cancer, or ALSYMPCA trial, was published in the New England Journal of Medicine. This demonstrated the efficacy of radium-223 in the metastatic castrate-resistant prostate cancer population. This phase 3 trial randomized 921 men with castrate-resistant prostate cancer and bony mets to either radium-223 plus the best supportive care versus placebo plus best supportive care. And the distinctive feature of this study is that there was a liberal definition of the best standard of care chosen by the treating physician. This could have included local radiotherapy, corticosteroids, ADT, estrogens, or ketoconazole. An updated analysis here occurred when the first 528 deaths resulted. And we can see here the Kaplan-Meier survival curves show that there's a better overall survival and also an improved overall time to first symptomatic skeletal events. As for the secondary endpoints, we can see that there is radium-223 had significantly improved benefits, including median time to increase of alkaline phosphatase and PSA. With that, in May 2013, the US FDA approved the radium-223 for treating patients with metastatic castrate-resistant prostate cancer and symptomatic bony mets. And in Canada, radium is used for osteoporosis, but it's coming up for also for patients who are with metastatic bony mets. It's already here, yeah. So in conclusion, I'm hoping what we did here is that we reviewed the physiological aspects of bone homeostasis and clinical assessments of bone health, and we assessed bone mineral density and how we can risk stratify patients for increased risk of fractures. We also discussed skeletal metastasis and prostate cancer and the effects of androgen deprivation on bone health. We finally looked at a quick overview of all the management options for skeletal health from the perspective of possible patients that we can see in the clinic. Thanks so much for your time, and I really want to thank Dr. Soul for all his help. It's been amazing. And the residents, Mike Robinson's not here, but Samir and Mike Metcalf were amazingly helpful in getting this together, so thank you.